Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam from Houston, Texas. Cardiology seminars are brought to you by Triple N Media on our YouTube channel. We have more than 200 lectures on cardiology. We welcome you to watch them, and please do subscribe to our YouTube channel. The information provided here is for education and for entertainment purposes only and is not a professional advice. If you want me to research on any topic and prepare a video, please let me know and I'll be glad to do that. If you would like to receive a copy of my cardiology rotations manual, I will tell you how you can get a free copy of this at the end of this presentation. So let us begin with the feature presentation, which is hypertension management in diabetic patients. This is a chart from the American Heart Association showing the criteria for hypertension. The normal blood pressure, the systolic is less than 120 and a diastolic less than 80 millimeters of mercury. And you have stage 1 hypertension if the systolic pressure is 130 to 139 over 80 to 89 millimeters of mercury. Stage 2 is 140 or higher and a diastolic greater than 90 millimeters of mercury, and hypertensive crisis is defined as a systolic pressure greater than 180 with hypertension mediated organ damage. However, some of these numbers may change when we are talking about a diabetic patient. When we are dealing with hypertension patient, whether the patient has diabetes, heart disease, kidney problem, or vascular disease, the general approach has to be the same. First, we need to have a team approach. It is no longer a doctor prescribing and expecting the patient to take, because the patient has to do much more than what a doctor does in order to maintain their blood pressure and keep it from going up. So we need an accurate measurement of blood pressure to start with. We need multiple readings, and this is the best time for the patient to get one of those blood pressure machines they can use on the wrist or on the arm and monitor the blood pressure and keep track of the blood pressure. Then we need to look at optimal blood pressure targets, which I'm going to talk about particularly for diabetic patients. Of course, we need to be cognizant of the hypertension complications, namely atherosclerotic heart disease, peripheral arterial disease, kidney problems, and other conditions. The first step would be lifestyle modification. I'm going to talk about that in a minute and help you as how much benefit one gets by doing lifestyle modifications, because the lifestyle modifications have to be done no matter what, whether you have diabetes, hypertension, kidney problem, heart disease, or vascular problem. You have to adapt to these lifestyle changes. There is no option. Medications, and we need to be concerned about the cost of medications when we prescribe these to the patients, especially in the elderly population who are dependent on limited income source. Then we need to talk about supportive measures. What else can the patients do in addition to just taking medications? Follow up at regular intervals, monitoring the blood pressure and adjusting the medicines will help to minimize cardiovascular complications from hypertension and minimize wide fluctuations in blood pressure, thus reducing hospitalizations for hypertension related complications. Here are the lifestyle modifications. Yes, none of us like to do it. We all know what we are supposed to do, but I will do it tomorrow. I just need a break today. No, I need to go and have a dinner today because this is a weekend. One day a week I need to get. Yes, we all have the same instinct, but let's look at the benefit. If you are a 40-year-old person who is moderately obese, who smokes and has unhealthy eating habits, here is what you can get by lifestyle modifications. Controlling your weight can drop your blood pressure by 5 millimeters of mercury systolic and 2 to 3 millimeters of mercury diastolic. Then healthy diet, reducing the salt intake, reducing the fat intake, reducing the cholesterol intake, will also help you by reducing your calories. You can bring down the systolic blood pressure by 11 millimeters of mercury. So by controlling weight, which is basically done through diet and exercise, you can literally bring down your systolic blood pressure by almost 15 points, which is a significant number if you are in stage 1 or stage 2 hypertension. Now let's talk about dietary salt intake. If we can reduce the salt intake, because the amount of salt we eat, especially if we are eating in restaurants, is astronomical. Make sure you reduce your salt intake, reduce the application of salt that's on the table. That can reduce systolic blood pressure by 5 to 6 millimeters of mercury. Now let's talk about potassium. We need to make sure we have adequate potassium intake. One of the rich sources of potassium is, of course, banana, but it also has 100 calories. So we have to balance. If you're going to take a banana, you need to cut the 100 calories from somewhere else in your regular diet regimen. Physical activities. Physical activities is a great way to lose weight, stay fit, feel energized through these endorphins. And by exercising for like 20 minutes, 3 to 4 times a week, you can reduce your blood pressure by 5 to 6, 8 millimeters of mercury and 2 to 4 millimeters of diastolic blood pressure. You can use aerobic exercises, dynamic resistances, or isometric exercises. All of them have positive benefit. But I would be a little concerned if you have severe hypertension doing isometric exercises, which increases your blood pressure. So keep that in mind. Of course, a reduction in alcohol to no more than 2 drinks per day could help to bring your blood pressure down. Now let's see if we can add up all these things. If your whole life has been going down the wrong path and you change your diet, you change your salt intake, you bring your weight down, and you get into mild to moderate physical activity, all of a sudden you can bring your blood pressure down with less, just lifestyle modifications, without a big sweat. And if you are one of those who doesn't like medications, I think here is your prescription. Let's talk about drugs. There are various kinds of drugs available for treatment of hypertension. We need to be familiar with these. First of all, we have the diuretics. They belong to the thiazide type of diuretics. Then we have the loop diuretics. The third group is the potassium-sparing diuretics. On the other side, we have the ACE inhibitors or ARBs. We have the beta blockers. We have the calcium channel blockers. We also have alpha blockers, centrally acting alpha blockers. Given all these medications, we should be able to treat patients with mild to moderate hypertension with lifestyle modifications in a very reasonable way and bring their blood pressure down and improve their quality of life far better than what they could have done without following lifestyle modifications and medications. The beauty of this is any one of these agents can be used as the first line of drug in treating mild hypertension after we have addressed the lifestyle modification. The drugs can be looked at as vasodilators, which dilate the blood vessels, reduce the peripheral resistance, like your ACE inhibitors and other vasodilators, calcium channel blockers. We have the sympathetic inhibitors like beta blockers and alpha blockers. Of course, we talked about the diuretics and renin-angiotensin, which reduces the peripheral resistance. It reduces the systemic vascular resistance and brings down the blood pressure. Here's a little trick. If the medication's name end with like April, these are ACE inhibitors like lisinopril, monopril, enalapril, captopril. ARBs, on the other hand, end with the word sartan. It's not Satan, it is sartan. S-A-R-T-A-N or sartan. Losartan, valsartan. Okay, alpha blockers end with O-S-I-N. Doxorubicin, terazosin, prazosin. Beta blockers, laugh a lot. No, it's LOL. Metoprolol, atenolol, nadolol, esmolol, labetalol, you name it. Calcium channel blockers end in, not all of them, but most of them in dipine, amlodipine, nicardipine. And diuretics, of course, end in IDE, furosemide, hydrochlorothiazide, hydrochlor. Now let's talk about recommendations for treatment of hypertension in a diabetic patient. First of all, we monitor the blood pressure. If the blood pressure is greater than 140 over 90 millimeters of mercury and less than 160 over 100 millimeters of mercury, we start them on one agent. We check for albuminuria, we get their EKGs, we get their echocardiograms and all the cardiovascular studies. They can be started on ACE inhibitors, ARBs, calcium channel blockers, or diuretics. Any one of these drugs can be used. Whereas if the patient has albuminuria, then you use ACE or ARBs and try to minimize the use of thiazide diuretics. Okay, the lifestyle modifications is the foundation of any kind of treatment, be it drugs, interventions, or anything else. Okay, then you follow these patients and continue the treatment. If the blood pressure is not under control, then we add a second drug, which could be from ACE inhibitors, calcium channel blockers, or diuretic group. Then again, you assess these patients and monitor them. On the other hand, if the blood pressure is greater than 160 over 100 millimeters of mercury, you start them on two agents. If they have no albuminuria, you can use ACE inhibitors or ARBs along with calcium channel blockers or along with diuretics. If they have albuminuria, again, you use ACE inhibitors or ARBs and calcium channel blockers or diuretics, and generally you would prefer loop diuretics in these patients. Okay, when the blood pressure is monitored, if it is not controlled, I told you we can add an additional drug. Adverse effects. If they are having adverse effects to like ACE inhibitors, they're having persistent cough and other symptoms, then we can switch them to ARBs or calcium channel blockers or use a different kind of a diuretic. When the blood pressure is controlled, you monitor them, follow them up, and continue to emphasize lifestyle modifications. If the blood pressure is still not controlled, we can consider adding mineralocorticoid receptor antagonists or refer them to a specialist to rule out secondary causes of hypertension like pheochromocytoma or renal artery stenosis or any other kidney problems that may be accounting for hypertension. So the key in diabetics is to keep the blood pressure around 130 over 80 millimeters of mercury. So that is the target, whereas in non-diabetics, it may be a little bit higher, like 140 over 90 millimeters of mercury. So that's one key difference with diabetics. Let's move on to, I'm just going to show you a list of drugs that are available for treating hypertension, whether it is in diabetics or in patients with renal failure or heart disease. The important thing I want to emphasize is try to learn one or two drugs in each class, like two diuretics, two ACE inhibitors, two ARBs, two calcium channel blockers, so that you're very familiar with the drugs, because you cannot use all the 75 drugs listed and try to become an expert on the topic. So as far as diuretics are concerned, we have, of course, hydrochlorothiazide, which is used, but it's chlorhalidone, which has been shown reduction in cardiovascular disease. When you're using diuretics like thiazide and loop diuretics, we need to monitor their sodium and also potassium levels. ACE inhibitors, there's a long list of ACE inhibitors, but you have to see what drugs are approved in a patient's formulary. That's number one criteria. Number two, be familiar with one or two drugs. I usually use lisinopril because that's what my workplace has, so I don't need to learn several different drugs. The dose of lisinopril is 10 milligrams twice a day, maximum 40 milligrams, and you titrate them. You can give it once a day. I prefer to give them twice daily because it's easy to keep a steady blood pressure. If lisinopril is not available, you can also try enalapril. So I would follow up with just a couple of drugs, whatever you feel comfortable, because they all do the same thing. ARBs. Look at the place where I work. Losartan is the most commonly used drug. So you can look at losartan or tamosartan or valsartan. Valsartan is a good drug to use, especially in cardiac patients, because if they develop stage 3 or 4 heart failure, then they can be switched over to Entresto, which has sacubitril with valsartan. So it makes it easier to know how these drugs behave in that particular patient. Calcium channel blockers are like amlodipine, felodipine, and nicardipine. All these things, there are the dosages. And when we use like drugs like verapamil or beta blockers, we need to be concerned about heart blocks, bradycardia, impotence with beta blockers. We need to be familiar with the most frequent side effects related to each class of drugs. ACE inhibitors, persistent cough due to bradykinin release in the lung tissue. And after that, we have the loop diuretics, which are more powerful than the thiazide diuretics, but they also cause significant hypokalemia, which we need to address. And there are drugs which are potassium sparing drugs like amiloride or triamtrin, but we need to use them in caution in patients with renal failure because they can develop hyperkalemia. So ladies and gentlemen, this is a very quick overview of hypertension in diabetics and how we manage them based upon their initial blood pressure levels and follow them in the clinic with a strong emphasis on lifestyle modifications. Our YouTube channel has more than 200 lectures on cardiology topics, and please do subscribe to our YouTube channel so we can keep you up to date as to the new additions to our cardiology library. If you want me to research on any particular topic in cardiovascular diseases, please let me know. I'll be happy to research and prepare a video for your benefit. If you would like to get a copy of my cardiology rotations manual, just drop me an email at drniknikam@gmail.com, and I'll be happy to send you a 180-page manual with chock full of information about dealing with cardiovascular patients. This has been a presentation of a Triple N Media. I am Dr. Nik Nikam, and I will see you in the next video.